Starts. Welcome to another departmental research evening. This has been a traditional activity of the Department of Surgery over the years. There was a hiatus for a few years, but we felt it was important to restart this very important activity. As you know, what differentiates a university from a college or a polytechnic or a professional institute is research. Research is a sine qua non that defines a university. And a university is therefore judged by the volume and quality of its research. And therefore, there is no apology for insisting that as a department that we have a research evening. And I am disappointed at the attendance. It may speak to the emphasis that our faculty may or may not place on research, but notwithstanding the poor attendance, we will press on this evening. I want to thank Dr. Belinda Morrison for putting together the research program, and Ms. Bennett from the Department of Surgery for facilitating the program. We are very grateful to Medical Protection Society for their sponsorship. Without them, this activity would not be possible. But most importantly, we are grateful to the residents who have gone through the trouble to put their research together to present it this evening. We are grateful to two judges who will be here with us this evening, Professor Gossel Williams, who is seated in the front row, and Professor Marvin Reed, who is judging from a distance online. Your third judge will be yours truly. So without further ado, I want to thank those who are present for coming to this important activity. And without further ado, I am going to invite Dr. Errol Williamson. Will you be going first? Dr. Errol Williamson will be presenting on the current state of point-of-care ultrasound use in the emergency departments in Jamaica's southeast region. Please put your hands together and welcome Dr. Williams.
All right, good afternoon, everyone. I'm Dr. Errol Williamson, a final year resident in the emergency medicine program. The title of my research project is The Current State of Point-of-Care Ultrasound Use in Jamaica's ED Hospitals in the Southeast region, and my supervisor is Dr. Simone French. Introduction. POCUS, point-of-care ultrasound, is the bedside use of ultrasound. It's a vital tool that enhances It's a vital tool that enhances clinical decision-making and expedites patient care. This modern tool is used by the bedside for diagnosis, resuscitation, monitoring, and procedural guidance of critically ill patients who present to a modern emergency room. Jamaica, however, is a developing country where many hospitals have limited access to advanced imaging technologies. Unfortunately, not all hospitals are equipped with this machine or device. This study explored the use of POCUS and barriers to its utilization in a selected Jamaican ED hospitals. The aim of the study was predominantly to determine the availability of POCUS, its utilization, and possible barriers to its use in the Southeast region. The primary objective is to compare the proportion of doctors and medical directors working the EDs in the hospitals reporting access to the bedside ultrasound use. And secondary objectives, to evaluate how many physicians work in the EDs in the region that have access to training, and to identify possible barriers restricting its use among doctors in the region. The methodology. This study was a prospective, descriptive, cross-sectional, multi-center study conducted over a 4-month period in 2024. The study was approved by the University of the West Indies and the Ministry of Health and Wellness Ethics Committees, respectively, and permission was sought directly from each local hospitals at the selected sites. The predominant research tool was a self-administered survey. These were the study sites. Why the Southeast region? The Southeast region was selected because it serves just under 50% of the population of Jamaica, and it comprises of a diverse mix of urban, suburban, and rural hospitals. 6 24-hour ED hospitals were selected, and they were as follows: the Kingston Public Hospital, Bustamante Hospital for Children, Spanish Town Hospital, Linstead Public Hospital, Princess Margaret Hospital, and University Hospital of the West Indies. This is a table that represents the 6 study sites, their characteristics, and the corresponding participant pools. It comprises of urban study sites, only suburban site, type B, Spanish Town, and the 2 rural hospitals, Linstead Hospital and Princess Margaret Hospital. The methodology. The inclusion criteria is that all ED doctors working in the Southeast region of the selected hospitals were included. Exclusion criteria: non-ED doctors, doctors outside of the region, doctors operating in hospitals less than 24 hours, doctors who work in private hospitals, doctors who are sessional doctors towards these sites. In terms of the data collection, it was a voluntarily anonymous self-administered survey that was it was available in a paper and electronic format, and it took at least less than 5 minutes to be completed. The methodology now. The surveys assess the ED doctors' views on POCUS training, availability, use, and barriers affecting its use. The ED heads of departments and the general physicians received separate surveys, and the data was securely stored and analyzed using the SPSS and descriptive statistical tools. The results. The overall study had a participation around 70.2%. Total number of participants was 178. All ED heads of departments had participated, and around 69.2% of the general ED doctors, which comprised around 119. What was found is that POCUS was available at 5 out of the 6 ED hospitals. In one site, the device had to be shared with another department, and another device was not functioning at all. And what was noted was that urban and suburban sites had greater access than the rural sites. The attitudes towards POCUS. All ED heads of departments agree that ED physicians should be skilled with POCUS. 88.2% of ED doctors strongly agree that the POCUS is essential, and this shows a strong consensus that it's a core ED skill. Regarding training exposure, heads of department, 2/3 of them receive formal POCUS educational training, and none of them receive such in medical school. But for the general ED doctors, 39.5% of them receive their training from self-directed learning, and this could be from online websites or YouTube. 38% receive local ED trainings from their heads of department, and 18.5% receive no training at all. And just in comparison as well, just around 26.1% receive training in medical school. This is a table here showing the views of the doctors on who should fund training. And the gross majority states that Ministry of Health, 71.4% state that Ministry of Health should fund or sponsor training. Other results. POCUS utilization. Among the sites with access, 60% of head of departments use POCUS, 91.3% of ED doctors use point-of-care ultrasound. And in terms of the frequency, it's varied. Regarding imaging quality, 20% of ED head of departments report that their POCUS device oftentimes give poor imaging quality, and 30% of ED doctors said the same. Regarding common POCUS applications, the most common application used in emergency departments was focus assessment, sonography in trauma, and extended views. 70% use it for pregnancy assessment, 63% use it for gallbladder assessment, then DVT, etc. As you can see, trauma remains the dominant indication for the use of POCUS. Regarding the reported barriers to its use, lack of training was reported as the #1 barrier for doctors, followed by inadequate training. Others report faulty equipment and poor supplies. A third report around lack of confidence and confidence in their interpretation. But from the emergency head of departments, half of them state that there's no quality assurance program for its use. Discussion. The key findings in context. POCUS is available in the region. However, its availability is uneven. It's highly utilized, but its use is inconsistent. And these findings align with the lower middle-income countries and global ED literatures. It confirms that POCUS is valued, but it's under-supported structurally. Training gaps and workforce implications. While regarding training in the region, training is fragmented and informal. The study shows that POCUS is widely recognized and essential, and there's a generational difference regarding its training. Younger physicians are more likely to be exposed during medical school, and there's limited undergraduate exposure. And this emphasizes that there needs to be a structured, longitudinal POCUS educational training program. Regarding equipment, quality assurance, and system use, a significant proportion of doctors report that POCUS devices have poor imaging quality, and the absence of quality assurance. This absence actually would inhibit skill retention, feedback and governance policies, and the lack of radiological support for ED POCUS-based interpretation can also affect its use. Recommendations. What I found from my study is that expanded standardized POCUS training should be employed in all ED levels. There should be an implementation of an ED-led quality assurance and POCUS coordination to improve skills. Should ensure that there is a reliable, dedicated POCUS equipment in all of these 24 ED hospital sites. Should prioritize rural EDs to reduce access gaps to advanced imaging. And Ministry of Health and Wellness should secure support, funding, and establish some amount of standards to employ and increase the use of ultrasound use. Limitations from a study. The study limitations, a lot of self-reported data was done, and recall and social desirability biases might have influenced the results. The survey tool that was used was not externally validated, and in terms of the imaging quality, it's a kind of subjective, and it might not give a proper representation of such. There might be a possible overrepresentation of enthusiastic POCUS users, and the study is only limited to the southeast region of Jamaica, which may not be employed or used in other regions. And the findings may not be compared to other Caribbean settings. So in conclusion, POCUS is widely recognized as a valuable in the emergency room. It's an essential tool in modern emergency department, and this study confirms the strong support for its use in emergency departments. Education, better access, and quality insurance programs can reduce some of these barriers, and improve POCUS use with enhanced patient outcomes. Thank you.
We want to thank Dr. Williamson for that presentation. I now open the floor for any questions or comments related to Dr. Williamson's presentation. Well, if there are no comments, yeah.
First one has to do with recruitment. You could explain how you actually went about doing the recruitment. And then the second question is, you use the terms urban and suburban. You had 6 hospitals. I'd love to know how you define that and which hospitals are considered urban and which ones are suburban.
regarding the recruitment process, I had to do sensitization at some sites. Each head of department was sensitized prior to the carrying out of the study. I actually had to travel to some sites and do a sensitization presentation prior to it being done. And in sites that I wasn't able to do a sensitization presentation, I had to do a thorough explanation to the staff. The second question was, okay, urban versus suburban. Just, okay. All right. Let me carry my table. Okay. All right. So I have my table here of my study groups and their characteristics. As we can see, the urban hospitals are University Hospital of the West Indies, Kingston Public Hospital, and Bustamante Hospital for Children, and that's located in the Kingston area. Spanish Town is kind of a suburban population because it's not fully urban, and a lot of the catchment area is from rural areas. And Linseed Public Hospital is a rural area, and Princess Margaret Hospital in St. Thomas is rural as well.
Okay.
So if I may, Dr. Williamson, there are specific definitions for what is considered rural and urban based on the amenities that are available and the population and so on. So I'm not sure if it's appropriate to call Spanish Town Hospital a suburban hospital. That's quite urban. And perhaps for the other areas that you labeled rural as well, there's a strict definition for what is considered urban and rural based on the amenities, like whether you have a firehouse and a post office and what amenities, social amenities are available and so on. Thank you for your presentation.
Thank you.
So moving along, we have our next presenter, Dr. Yannick George Johnson, who is going to be presenting on a cross-sectional study comparing single versus combined routes of administration of tranexamic acid in primary total joint arthroplasty. Does it impact blood loss? And of course, this is from the section of orthopedics. Please put your hands together for Dr. Yannick George Johnson. He's not here? Okay, sure. Okay, if Dr. Johnson is not here, we are going to move on to Dr. Parker. Dr. Parker is a chief resident in the section of urology, or the urology unit, and he's going to be presenting on the impact of surgical management of testicular torsion on semen parameters and fertility outcomes. I want to remind the presenters that they have 10 minutes in which to present. Welcome, Dr. Parker. Please put your hands together.
Hi, good afternoon all. So a very dramatic title slide, Death in the Scrotum. A very dramatic picture. It's an obviously dead, very hemorrhagic right testicle from testicular torsion. My topic today, or the topic of my research paper, is the effects of testicular torsion and its treatment on the semen parameters of patients at the two main referral hospitals in Kingston, that's KPH and UWI. And the investigators were myself, Garfield Parker, Doctors Morrison Blidgen, Christy, and Carol. I like to give a bit of background as to how come I ended up with this research topic. Essentially, it's a bit of an interesting story. Like most of the other interesting stories throughout training, it started with a general surgeon. I was a junior resident in general surgery at a peripheral institution, took a patient with torsion to theater, removed the testicle because it was a bit questionable, and was proud to tell the general surgeon the next day that I took it. And the surgeon asked me, why did I remove the testicle for this young gentleman? I told him, obviously, it was questionable, and there's a risk of sympathetic orchidopathia, which is the contralateral testicle can also be affected if this ipsilateral testicle remained. And he asked me, challenged me with giving him evidence to support same. I looked and looked and looked and looked, and I could find no definitive evidence to support same. So I sort of piqued my curiosity at that time, and I decided to take it on as a research topic to see if I can sort of figure out why this is so. Testicular torsion, as we know, is the twisting of the testicle along the spermatic cord's axis. It's a true urologic emergency, something that we stop the theater for, take the patient from the emergency department straight to the OR, and it's usually time sensitive. So if we get the patient sorted within a reasonable time, usually about 6 hours, the testicle tends to survive. Longer than that, they don't tend to do as well. There is a question, as they would have been alluded to from my little story, that there's a question as relates to controversy as to the effects on semen quality and fertility in these patients. Quite a few studies have been done, a lot of them quite long ago, a lot of experimental studies in rats, etc. in the 70s and 80s. But no, it's really just 50-50. Some studies saying that there is an effect on semen analysis, there is an effect, histologic effect in the contralateral testicle in patients who had torsion. But similarly, there are equal amount of studies that sort of refute this hypothesis. As a matter of fact, the overall sort of incidence and epidemiologic data in the Caribbean is quite sparse. I was hoping to get some information on this also. My hypothesis was therefore there is no significant difference in semen parameters of patients post-PECSI or orchiectomy for testicular torsion compared to men who've never had torsion. And the aim was to determine the effect of the management of testicular torsion on fertility and semen parameters in patients at the 2 main referral institutions. The time frame that I looked at was January 2010 to December 2021, quite a long study period, and that's just I could have gotten the sort of amount of data to get meaningful information. So it was a retrospective cohort of all men who had surgery for testicular torsion within the study time frame. As I said, the sites were UE, KPH, and we managed to get some controls from the UINT fertility management unit only out of convenience. The data source was medical records, so we went through all the medical records, all the surgical operative notes, and we would have contacted these patients via telephone, invited them to a face-to-face or telephone clinic appointment to see, general wellness check, how they're doing, if they have any issues since surgery, if they have any fertility concerns. And then we took that opportunity to also ask them if they wanted to take part in this study. If they agreed, we then administered a questionnaire as relates to fertility. And if they went through the questionnaire, we then invited them to do a semen analysis, and they would give consent for all the above. The objectives primarily was, as I said, to compare the semen parameters, the semen analysis post-surgery for testicular torsion with age-matched men from the healthy Jamaican population. And secondarily was to just get general information on testicular torsion incidence and a little audit done. Inclusion criteria: had to have had surgery for testicular torsion, must have been at UE or KPH, must have been within the study period, must have been old enough to consent. They would have been willing and able to provide informed consent, and no sort of limitations to prevent them from doing same. And the exclusion criteria was quite the opposite. After going through the information, all the records, we got a total of 242 patients, so by far not a very, very large data set. And after obtaining this information, we then reached out to patients, and we were only able to get 77 of them via telephone in order to invite them for the clinics. Of the 77, 70 of them agreed to do the questionnaires. Of that 70, 26 agreed to semen analysis. Of the 26 who agreed to semen analysis, only 13 showed up for the semen analysis. As you could imagine, it's a bit difficult to get our patient demographic to come in to do something like that. We did manage to get some information as relates to impregnations, or number of impregnations and number of children that these patients would have had. Total number of impregnations was about 44, and the total number of children was about 20 in the patients that we interviewed. That gave us a median of about 2 children per patient, and impregnations about 1, a median of 1. So based on this very crude information, generally speaking, we saw no significant association between the number of children or number of impregnations and the type of surgery performed for testicular torsion. The procedures performed reflected that we have a very high testicular loss rate, and this reflects the sort of how the patients present and are worked up from the GPs, emergency departments, and these sort of things. So almost half of our patients, very, very young guys, end up losing their testicles. The data also showed a very strong correlation between the time that the patient presents and the type of surgery performed. So overwhelmingly, patients that presented within 6 hours kept their testicle, and overwhelmingly, patients that presented greater than 24 hours after the onset of pain tended to lose their testicle. Coming down to the data that we're very much interested in, which was the semen analysis. As I said, only 13 men were able to donate a specimen. And of the 13 that were able to donate, only 3 of them met the criteria for a normal semen analysis. Right? So overwhelmingly, most of the patients that had testicular torsion, regardless of the type of surgery they had done, had some significant abnormality in their semen parameters. And it was equally split either pexy or ectomy, whichever one was actually done. So 30% of them had low volume, almost half of them had low concentration, and up to a quarter of them had low counts. And these are all quite low, the lower end of low normal, of the low value. When it came to comparing them with the controls that we have, again, not surprisingly, it showed that there was a significant difference or a significant reduction in semen parameters of the cases compared to the controls. In terms of the incidence, using the 2011 Jamaican census, looking at the males in Kingston, we had an annual incidence rate of about 14 per 100,000 patients per year. For gentlemen younger than 25, which is equivalent to the sort of general rates that you find in other studies, which is quite modest, but the important thing is that it has significant consequence because, as we said, half of these patients tend to lose their testicle. So from the study, the strongest information that we have is that delay in surgery definitely leads to testicular loss, so we definitely need to improve on this via patient education and staff education. Strong signals in fertility is that there's definitely a decrease or a reduction in semen quality in patients who've had testicular torsion. We don't quite know why. And there's no difference between patients that had a pexy or ectomy in terms of their semen parameters. Null findings within the semen subgroup that I said, there's no difference in the quality depending on the type of surgery done. And overall, the data was a bit mixed, and that was because we had quite a bit of limitations for the surgery, not least of it, quite a bit of limitations for the research, not least of which was a very, very small sample size. So key limitations to the retrospective design over a very, very long period of time, but based on the nature of the pathology and how we follow up the patients, which is a very, very, very short follow-up, probably 3 months, if anything at all. This was the best that we could have done. We were only able to get 77 patients. Most of the numbers, 170 plus, went to voicemail or were wrong. We had a very long interval between the testicular torsion and doing their semen analysis, allowing for other confounding agents. The control had a significant selection bias because we took them from the fertility management unit, but we sort of appreciate that it would be very difficult to recruit men from the general population. Offspring and impregnation data were quite limited. Bottom line, the results were hypothesis generating and clinically useful, but not definitive. So it gives us a lot to think about, but we still have a long way to go. And that was the end of the presentation. Thank you.
Don't go too far, though. We want to thank Dr. Parker for that presentation. Are there any burning questions? Or questions from the judges? Or yes, Dr. Baker.
I would say the semen quality would have given us more information. The number of children, it's a good surrogate. The issue is that we don't have the facilities to start to confirm children to parent. So that's a little bit of a limitation if we do that way. No, 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 not at all. Their rates of spontaneous insemination and getting kids is a little lower, but they certainly can reproduce. Based on my research, I didn't analyze for that.
So there's a concept of patient-centric assessment and laboratory-centric assessment. And certainly it seems to me that it's one of those situations that you might overcome a lot of the hurdles that you have at the progeny and how well they're able to have children as opposed to lab parameters.
Yeah, the other limitations that, as you saw, the number of patients that reported or that had children is still small, is still 20. And that's because the patient population is also quite young. So a lot of our patients, the mean age is about 19 years. So a lot of these guys aren't interested in having kids just yet. A lot of them don't have kids as yet. So from that standpoint, it's still difficult to assess it based on progeny.
If a gentleman has abnormal sweet semen parameters, but has professed having a child, that he has a problem? Did he answer him, Dr. Parker?
He has a problem?
Yeah, that's what he asked.
I
If he has a
don't
problem.
think he has a problem. He has a child. That's not a problem at all.
He has a problem.
It's not a problem.
He has a problem.
But either parameter has limitations. So a normal or abnormal semen parameter doesn't guarantee that you will have children and not have kids. But having progeny, that isn't necessarily, you'll have to prove by a DNA testing that this is absolutely your child to confirm that that's the case.
What I'm talking about is something conceptual. So what I would suggest is that you read about patient-centric analysis, because I think that this is a classic example of that. And it might actually help you in terms of getting the numbers that you want for meaningful publication.
Fair enough. Thank you, Dr. Baker.
If I may, Dr. Baker, looking at number of progeny or progeny as a whole would be problematic because there are so many other variables that could affect that, including coital frequency, female factor infertility, etc., etc. So the surrogate Markov semen parameters, I think for a short-term study, is a better parameter than the progeny because of all the other variables that could affect it. Okay, so I think that. Okay, there's another question.
Indicate that I did have a concern about quality because what I saw was decrease in semen volume. That's not what I understand quality to mean. So I think you need to think about that definition. My question though really relates to the fact that I saw mention of controls and I'm trying to figure out where did controls come in the recruitment. I saw that you were recruiting men that had surgery for this thing. And then all of a sudden, I see control pop up. What are these controls?
So first of all, in terms of the semen quality, we didn't only look at volume. We also looked at concentration and total count. And the data is here. Overall, it's low. Well, there are different parameters looking at an abnormal semen parameter or semen analysis. There are 6 or 7, well, more than that. But the common things that we look at, 3 major things we look at is volume, concentration, and count. Other things like motility, morphology, pH, color, and these sort of things can also be looked at, but that is a more of a larger, complex sort of picture. This is a very simplistic view. When it comes to the control, essentially what I wanted to achieve was to get an idea of what the average semen parameter in a Kingston, somebody born in Kingston male is. And I was trying to see how best I can get that information, because you know semen count varies place to place, country to country, and these sort of things was normal overall. But I didn't find a more ideal way of getting a sort of a cohort, like compare the study population to. So that's how I settled on some gentlemen from the age-matched patients from the Uinta Fertility Management Unit. And recognize that as a significant limitation in terms of selection bias.
Thank you, Dr. Parker. Please put your hands together for him. Okay. Okay, our next presenter comes from the Pediatric Surgical Department. Dr. Sashai Christian will be looking at an evaluation of the risk factors associated with postoperative complications in children treated for Hirschsprung's disease in Jamaica, and she'll be doing a 10-year review. Please welcome Dr. Christian to the podium.
Good afternoon, everyone. Thank you for that introduction, sir. This evening or afternoon, we'll be looking at an evaluation of the risk factors, as said before, associated with children we have been treating for Hirschsprung disease in Jamaica over a 10-year period. Now, what is Hirschsprung's disease? This is a congenital condition that is characterized by the absence of ganglion cells or nerve cells within the rectum, often extending proximally to the colon. In this very interesting picture that you will see on the screen, you'll have an area of the intestine that is quite narrowed, and that's the portion that lacks the nerve cells, and you'll have this arrow pointing to the transition zone. Not sure if you're seeing my cursor, but pointing to the transition zone where you'll have a transition from abnormal to normal bowel, and this dilated portion of intestine has ganglion cells. How these patients will typically present is with a history of delayed passage of stool at birth, abdominal distension, constipation with a reliance on laxatives, and in very unfortunate cases, failure to thrive. So how is it that we treat this condition? Of course, it's surgical by the means of a pull-through procedure. If you can follow this diagram that you're seeing on the screen, the area of the intestine that has the red dots, that would represent the area of the intestine that lacks the nerve cells or ganglion cells, and the area that is in green is the normal portion of bowel with ganglion cells present. So in the middle picture, you'll see 2 black lines going across, and that's the area that we will resect and pull down that healthy ganglionic bowel and form our anastomosis. And that is how we treat them surgically. Now, it is the hope of everyone involved, the patient, the parent, the surgeon, that after surgery, the patients will have improved bowel function and they will thrive postoperatively. However, as we know with all procedures, there are complications. Now, the rates internationally, they vary quite widely. Persistent constipation, as per one source, ranges between 9% and 40%. Hirschsprung's associated enterocolitis, which is a form of inflammation of the bowel, which is associated with mortality in these patients, occurs between 25% to 37% in one source, and another source quotes as high as 45.8%. Fecal incontinence, if you look at this rate here, you see it varying quite widely, and that's largely because the standard definitions are different across different studies, or in other words, there are limitations to defining what fecal incontinence is, and because of that, some studies would quote lower volumes and some studies would quote higher volumes. Nevertheless, in the Caribbean, we really do need more information on our patients. Vincent and Jackman in 2009 in Barbados did a study, and they looked at the outcome of the patients that they had this pull-through procedure performed on, and they found that 69% of them had good bowel function afterwards. Our very own Professor Duncan in 2011 looked at patients who were treated for Hirschsprung's once they were over 10 years old, and we refer to that as adult onset Hirschsprung's disease. Now, it's the aim of this study to really continue the path of getting more information within our local regional setting so we can improve the outcomes in our patients. So in terms of this study, in reviewing the literature, what has been found is that there are certain risk factors that are present that puts the patient on or puts them more at risk, for developing these complications post-operatively. One, if they have that inflammatory condition of the bowel prior to surgery, that is pre-operative enterocolitis, the older age at the time of surgery, the presence of associated syndromes, for example, trisomy 21, those patients are at more risk of developing enterocolitis. Pre-operative undernutrition and anemia, and of course that speaks for itself with regards to healing post-operatively, and the need for intraoperative blood transfusion, as that would indicate a hemodynamically unstable patient. Protective factors against poor outcomes, so if the babies have the surgery at a younger age, if we perform something called a leveling colostomy, which is a type of diverting colostomy where we would take a portion of bowel that is healthy and has ganglion cells to shunt the stool away from the problematic bowel to decrease the risk of inflammation happening throughout the bowel. Pre-operative bowel preparation, of course, if it is that we have stool-free bowel at the time of surgery, it reduces the risk of surgical site infections, and the utilization of ancillary tests such as immunohistochemical staining on our biopsy specimens so we can get answers in terms of diagnosing these patients faster. So the hypothesis of this study is that these protective factors which have been stated and identified in the literature are indeed applicable in our setting. So this is a retrospective observational study, and the study period was from January 1st, 2013 to December 31st, 2023, and the patients were aged 0 to 15 years. And the aim, of course, to determine the number of Hirschsprung's cases of Hirschsprung's disease managed between this University Hospital and the Bustamante Hospital for Children, to determine the number of patients who develop these post-operative complications, to identify whichever risk factors we can that contribute to their outcomes, and of course, compare our outcomes to international best practice. So if you can bear with me here, what I had to do is just take little snippets of the data collection table, as it is quite extensive, and this slide, in addition to the other, doesn't cover everything, but just to highlight some of the important factors that we wanted to elicit: the age at which they're diagnosed, the age of onset of symptoms, the age at which they're referred to surgery. So at what age do we see these patients to actually start treating them, to diagnose them in order to start treating them, what symptoms they have prior to diagnosis, including that enterocolitic condition, which can make their post-operative course more stormy. If they have genetic syndrome such as trisomy, the year, the age at the time at which they have their definitive pull-through procedure, if we performed a diverting colostomy, and in terms of the complications post-op, we list them in terms of constipation, enterocolitis, and soiling. We want to know the age at which it occurs, the time of after surgery, the number of episodes they have, and how severe it is. And of course, whether or not over time these patients improve or resolve. So In terms of what has been obtained so far, 51 records were reviewed, and the statistical analysis is not yet completed. However, I would present the preliminary findings. So what we can see here is that majority of our patients start having symptoms in the neonatal period. So we see that 72% of them actually have symptoms within the first month of life. And if you look at the other pie chart, I really wish the cursor was showing up. Okay, great. Right, so if we look at the other pie chart, we realize that in terms of the age of referral to surgery, we only get 41% of them in the neonatal period, which is important as we'd want them as early as possible so we can diagnose them and treat them early. In keeping with international information, it's more common in males and females at a 4-to-1 ratio. In terms of our study, it was 3.5-to-1 male to female ratio. Okay, so in terms of the post-operative complications, what we found in our study was that of the 51 patients, 45% of them had that inflammatory condition of the bowel post-operatively, that highly lethal condition, and that's referred to as post-operative enterocolitis. 25% of them had persistent constipation and 31% of them had fecal incontinence. Well, do we fall within international standards? Yes, we do. And I just highlighted the previous rates that were quoted prior in terms of what is found internationally. But of course, there is always room for improvement. What I would say is that particularly for one of these parameters, the fecal incontinence, as we can see in the international literature, the range is so wide, 8 to 74%. And as I said before, it's due to a lack of standardized definitions, because even in going through our data, some patients probably didn't have true incontinence. They were constipated, and you had a lot of leaky watery stool just leaking from the anus, and it was determined as them soiling or being incontinent when it wasn't a true sphincter dysfunction. And that is something out of this study I would like to employ in future practice, where we have checklists so we can ask the relevant questions and document them so we can stratify the patients accordingly. Other patient factors, preoperative HAEC. Remember, as I said, that inflammatory condition, if they have it preoperatively, they can have it postoperatively. We find that 56% of our patients had it preoperatively. So 56% of those who had it postoperatively had it preoperatively. One patient had trisomy 21, one patient had a neurocrystopathy, which is called Waardenburg-Shaw syndrome, which puts the patient at risk for Hirschsprung's disease. In terms of the nutritional status of the patient at surgery, we look at their Z-score to ensure that they're adequately nourished. The age of pull-through procedure, we do find in the literature that the younger the pull-through procedures are done, the better outcomes, the outcomes are. And as you can see, majority of our patients have the pull-through procedure done when they're over 3 and less when they're less than 1 year old. So, in terms of bowel preparation, all of our patients had it, and that's to reduce the risk of infection. So essentially, what do we hope to achieve? To risk stratify our patients, to identify preoperative risk reduction strategies that can be used to decrease the postoperative complication rates. We did find that more than half of our patients over time got better, and that's very satisfying. And it's also reassuring to the patients and the parents, but it reiterates the need for special attention, designated clinic days, and talking to the parents and the patients about what to expect. Unfortunately, one of our patients 20154, passed approximately 3 weeks ago from that lethal condition that I said before, postoperative enterocolitis, and that makes the mortality of the study 1.9%, which is within internationally accepted standards. So it just stresses the importance of knowledge of this condition to reduce the risk of mortality from this. And what has been done at the Bustamante Hospital, this has been in the stages of being implemented for the staff as well as the patients to see these effects or these symptoms of enterocolitis and identify it. We also hope to get a little space in this book, this well-known passport that indicates meconium passage, as it might indicate to the clinician who is managing the patient with constipation. They may have to look back at this and find that the patient did have a delayed passage of meconium at birth, and that will shunt the patient to surgery earlier. And just to finish up in terms of the limitations, the ICD coding is kind of tricky. It encompasses a lot of constipation-related conditions, so it actually will make you think there are more patients than there actually are until you start going through the dockets. Some dockets are purged or misplaced, and that lethal condition, enterocolitis, can look just like gastroenteritis, which is what happened to that patient that died. And so it's important for us to make everyone aware, all staff are aware of what it looks like, so the patients can be treated quickly and appropriately. Thank you.
We want to thank Dr. Christian for her presentation. I'm sure there are a few questions, and I'm going to lead off with the first one. Your study was supposed to be looking for risk factors associated with postoperative complications, but what I saw was primarily a descriptive study. I didn't see you do any analysis for associations. How would you comment on it?
Okay, thank you, sir, for that question. So in this presentation, I highlighted the preliminary findings of some factors that were associated, for example, preoperative HAEC or enterocolitis, the fact that in our study population, the age at which the pull-through is done is older, which is in keeping with poorer outcomes in our patients. And so in terms of the analysis, because statistical analysis is still ongoing, I did not want to speak too early, so I would want to ensure that that is completed before I give final correlations.
Okay, thank you for that response. In my response to what you just said, I would therefore recommend for you to have put a preliminary study, or put preliminary in the title of your study so that we know that these results are not the final thing. Are there any other questions from the judges? I want to recognize the presence of our online audience. Unfortunately, we are not set up to take questions from you. I understand we have 30 persons online, and it is most unfortunate that we can't engage you in a more fulsome way. But we hope, nonetheless, that you will stay tuned to the very end. I think Dr. Baker has a question for you.
Hi, Dr. Christian. Did all of your post-op patients have complications, and did each patient have only one complication?
No, not all post-op patients had complications.
If you go back to your pie chart, that's what you suggested.
No, sir. I think, to be fair, I do agree that probably this wasn't the best way to represent it, because it looks as if everybody had a complication, but what I should have done was even stated to say that 45% of them had this, 31% had, and so it wouldn't be as confusing, so I apologize for that.
Okay, thank you very much. Please, again, put your hands together. Okay, our next presenter, again, seems to be from the Division of Orthopedic Surgery. Dr. Courtney Berry will present on tranexamic acid versus tourniquet in visual clarity in arthroscopic ACL reconstruction. Please welcome Dr. Berry to the podium.
All right. Good evening, everyone. So I'm Courtney Berry. I will be presenting on behalf of the orthopedic department. So we're presenting a randomized clinical trial of tourniquet versus tranexamic acid in visual clarity in arthroscopic ACL reconstruction. And this study was carried out at the University Hospital of the West Indies over the last 18 months. no disclosures, no conflicts, no industry funding, and this study was approved by the Youth Ethics Committee. So why does this really matter? So as we can see, the ACL is the most commonly injured ligament within the knee, and it ranges from an incidence of about 30 to 70 per 100,000. So why does visual clarity really matter to us? If you can't see, you will have malalignment of the graft. Malalignment of the graft means poor surgery, failed surgery. And it is important as surgeons to see what we're doing, especially in orthopedics. So the current standard of care is to utilize a tourniquet, inflated around the thigh, 300 millimeters of mercury. Is it effective? No question, yes it is. Safe? Questionable. There are risks of nerve injury, muscle ischemia, pain, as well as DVT. So the question really is, can tranexamic acid do better? So tranexamic acid works by blocking plasmin, prevents clot breakdown. And it has been proven effective in total joint arthroplasty, spinal surgery, trauma, shoulder arthroscopy. And as of 2017, the World Health Organization has put tranexamic acid as an essential drug. It is safe, low cost, but does it work for us in the knee? So we asked, is tranexamic acid good as tourniquet in visual clarity for arthroscopy in ACL reconstruction? So our null was, there is no difference when comparison to tourniquet. Alternative hypothesis, there is a difference. And our study design, patients were recruited. Once they had been consented, they were randomized into a group. We had tranexamic acid group having 24, tourniquet group 27. The no tourniquet group had 1 gram of tranexamic acid, while the tourniquet group had the inflation of 300 millimeters of mercury and had a saline placebo. And it was double-blinded, both the surgeon as well as the patient. So outcomes measured, our primary outcome was visual clarity, grading from a 1, being the best visual clarity you can have, no bleeding, to 3, poor visibility. While our secondary outcomes, pain at 24 hours and at 2 weeks, as well as any adverse events. And this could be DVT, infection, readmission. So our patient population. So we involved all patients who had a primary reconstruction, also if they had a concomitant meniscal injury that needed repair, and these patients had to be greater than 18 years. We excluded patients who had revision ACL, multiligamentous knee injury, coagulopathies, sickle cell disease, and any patient on anticoagulation. So no patient was lost to follow-up, and we had a total of 51 patients. 24 in the tranexamic acid group, 27 in the tourniquet group. And the baseline characteristics, when we looked at age, female, gender, BMI, site of injury, and concomitant meniscal injury, the groups were balanced. Both groups were comparable. So that limited any kind of confounder within both groups. So the primary result of visual clarity, it showed an overwhelming perfect visibility for tourniquet group. All 27 patients had a grade 1 visual clarity. While in the tranexamic acid group, we had 54% having perfect visual clarity, and that subsequently decreased where 8 patients had moderate visual clarity and 3 patients had poor visual clarity. And the p-value for this was less than 0.001, which is highly significant. So what the surgeon saw. So visual clarity being a 1, clear view, no bleeding. Visual clarity 3, bleeding obscures the operative field. And that's what it would look like. Can't really see much, while perfect visibility on your left side. Graft trying to be placed, but obscure, perfect graft placement. So when looking at the pain analog scale, at 24 hours, the p-value for pain being controlled was better in the tranexamic acid group with a p-value of 0.04. And at 2 weeks, it was 0.7, which showed that at around that time, the pain control was non-significant in between both groups. So safety, there were no adverse events, no DVT, infections, wound complications, or readmissions. So both methods are safe. So when we look at the summary of results, tourniquet wins with a p-value of 0.001. At pain at 24 hours, tranexamic acid is victorious at 0.04. And at 2 weeks, it was a tie, and adverse events being 1. That adverse events showing that there's no significance between both groups is significant to us because we want to know that both are safe. So why did TXA really fail? So it has been proven in shoulder arthroscopy. So we have bleeding from soft tissue only. There are no bone tunnels, lower arterial pressure, and tranexamic acid works on clots. While in the knee, we make bone tunnels, and bleeding from bone and soft tissue, the higher arterial pressure really affects the clot being dislodged continuously, and that obscures our visual field. So the clinical take-home message, this means for your practice, use the tourniquet. It provides perfect visualization. It is safe with proper use. Consider tranexamic acid only if the patient has a tourniquet contraindication. You accept that around 8% will have poor visibility. And also, it has the benefit of reducing post-op pain. Limitations, so this was a single-center study, right? We utilized a smaller sample size that we initially had set out, but this was due to us assessing, doing interim analysis, and it showed that with the overwhelming perfect score for visual clarity, continuing would have showed no added benefit. Subjective outcomes, we had used a 3-pronged analog scale for visual clarity that the surgeons had used to really grade what visibility they had seen post-op. 2 patients in the tourniquet group, in the tranexamic acid group, were unblinded to the surgeon due to poor visibility. And there should have been probably a hybrid arm of tranexamic acid and a low-pressure tourniquet group. However, the effect was so large that these limitations did not really change the conclusion. These are the references stated. So to summarize, tourniquet is superior for visual clarity in arthroscopic ACL. Tranexamic acid reduces early pain but cannot replace tourniquet. I'll take questions. Thank you.
Yes. We want to thank Dr. Berry for that crisp, sharp presentation. I'm sure there, and within time. And are there any questions? Oh, Professor Gus Williams.
Experimental studies, clinical trials, and it sounded like you didn't have any funding. So I just wondered how you handled that bias, because I'm assuming you didn't take the money out of your pocket.
No, I did.
All right, so we have that kind of conflict there. The other thing now is I recognize the doctors can't be blinded. You can't, I mean, it's clear, obvious what procedure you're doing. So how did you remove that subjective bias? In other words, were you involved in the assessment?
Right, so for the blinding procedure, what we had is that the main surgeon who was doing the visual clarity grading would have been outside at the setup. So everybody had... Right, so the main surgeon who was doing the assessment of visual clarity was outside at the initial setup. So everything was applied, the patient, tourniquet was applied on a round, not inflated for everyone, but it was applied, right? So when the surgeon came in, the patient was draped already, right? If they were getting the tranexamic acid, they would have gotten it from the induction room by the anesthetist, right? So they would have not seen anything. So when it was time to do surgery, they would have just come in and they would have just started operating because it's arthroscopy, so it's just pinholes within the knee and it's on a camera. So really noticing if the tourniquet is inflated or not, wouldn't have really been an issue if they were inside at the setup.
Okay. That sounds good. Thank you.
Yes, we want to thank Dr. Berry and the orthopedic division for presenting this really interesting trial. I understand that Dr. Yannick George Johnson is now here, and he is going to be presenting a cross-sectional study comparing single versus combined routes of administration of tranexamic acid in primary total joint arthroplasty. Does it impact blood loss? Very similar to the previous study. Dr. Yannick George Johnson. Still not here? Oh, okay, he's coming. While he comes, I want to remind the audience that this evening's activity is sponsored by the Medical Protection Society. Okay, we're going to allow Dr. Yannick George Johnson to present later, and we are going to invite Dr. Lysandra Spence to come to the podium to present on her topic, which is arteriovenous fistulae assessment at the UHWI Fistula Clinic, a 5-year review, maturation, patency, and influencing factors. Before she speaks, I want to remind the audience that refreshments will be provided courtesy of Medical Protection Society at the end of the symposium.
Thank you. Doctor, what to use to press to go forward? Good afternoon. I'm presenting my research project. Thank you for the Clinical Research Committee as well as the department for the privilege and honor to present here. My name is Lysandra Spence Henry. I'm a postgraduate student, DM General Surgery. So my project was looking at AV fistula assessment at the University Hospital of the West Indies, a 5-year period, 2018 to 2023. So the reason for my study, or the background, end-stage renal disease in Jamaica is prevalent, and the prevalence that is documented is 143 per million population, done by Sayuba et al. In 2008. This was updated further in 2025 when Fisher et al. Looked at it and demonstrated a 14.8% CKD prevalence within Jamaica, and most of these patients require renal replacement therapy. And as you can see, this would result in an increased burden on the healthcare system, and as such, the need for vascular access, and why the surgeons would get involved. Kidoki, with their guidelines, which is a international guidelines, kidney disease outcome and quality initiative, prioritize AV fistula over graft and also over the central venous catheters. So it's a fistula first initiative. And in terms of data that has been done here, Cowish et al. In 2009 actually looked at AV fistulas within our population or at our university between 2002 to 2006. But there's not a very large analysis of our local maturation as well as the patency that has been performed yet. So the study scope, or my study, or the study that we did, is essentially potentially the largest audit in Jamaica as well as the English-speaking Caribbean, because even though it was performed at university, we would have received inter-parish referrals from other hospitals and other parishes. So it can be generalized to our national population, our population. Primary objective for the study was to determine the maturation rate, primary patency, and assisted patency rates of AV fistulas and grafts at the University Hospital Vascular Access Clinic between the periods 2018 to 2023 and benchmark that against international standards. The secondary objective was to assess how specific factors affected that maturation and patency. So that included patient age, the operating surgeon level, anastomosis location, timing from maturation to fistula, and CKD stage at the time of placement. So for the purpose of this talk, the main definitions I want the audience to get is AV fistula, which is an autogenous anastomosis or communication between a vein and an artery to arterialize the vein to enable 2-needle cannulation for hemodialysis. Then when we look on maturation, maturation is defined, and you have multiple definitions within the literature, but the definition that was used for this study was clinical or Doppler confirmed suitability of the access. And by that we meant, was it able to perform a 2-needle cannulation at prescribed flow rates, or clinically it was defined by the presence of a thrill. The primary patency was the interval between placement of access until the first intervention to salvage it, or when you essentially abandon it. Primary functional patency, on the other hand, was time from maturation to first intervention to maintain or to restore function. So the study was a retrospective cohort, and data was collected retrospectively, and essentially what was found was that 100% of the accesses were AV fistula. 279 AV fistulas were created over that period, and on 235 patients, and majority of the patients, 63%, actually had HD catheter, and majority of our patients or fistulas were placed 84% of the time in CKD stage 4. The importance of that is in our Kidoki guidelines, we actually want our patients to come earlier. So by the time they are CKD 5, they would have already had their access, and then essentially the catheter they wouldn't have had the catheter placement, which comes with a lot of complications. If you look at how our anastomosis locations were, for the majority of our population, the single stage, distal radiocephalic, as well as proximal radiocephalic, were the majority of our fistulas. We had less two-stage fistulas, such as brachybasilic, as you can see here. What did we find? Our fistula maturation, our overall fistula maturation was 75%, which is actually pretty good, because the international benchmark, international range is actually 40 to 80%, so we are right there. However, our maturation, overall maturation, was over the entire time, meaning the 24 weeks, essentially 6 months. And though we achieved it at in a longer time. This bar chart actually shows you where the single stage actually do much better. The single stage is in the light green, and the two-stage procedures are in the gold. And you can see there's a vast difference between the two. The Kaplan-Meier graph actually shows, and it highlights it even more when we refer to single stage or two-stage, where 50% of our single stage actually were mature by the 8-week mark, and then compared to now, that is looking at the B graft. You have a pointer? The B graft, where 50% would have been done in around 28 weeks. Our fistula patency rates, essentially, we also met the international benchmark for that, in the sense that for primary patency, which is time of placement to first intervention, we had a 1-year patency of 57%, where the international benchmark is 51 to 72%. However, we did pretty good in our primary functional patency, where at 1 year, 2 years, and 3 years, we can see where we are well above the international benchmark at 1 year at 86%. And the difference between that can point towards, one, we actually don't have as great access based on the retrospective nature, as well as at that period to interventional to kind of salvage these fistulas. I think if I were to expand on this study now, I would actually have something different in terms of the findings. When we looked at the maturation with the predetermined factors I stated before, what we found was maturation, CKD stage 5, had the best maturation, but that is in context where majority of the patients were CKD 5 anyway, and the surgeon level had an impact where the majority of the fistulas were created by the residents, but however, the majority of the failures were also within the resident cohort or the resident group. When we looked at time to maturation, we actually found no independent variable to actually correlated with the time to maturation. So none of the variables that we looked at affected time to maturation. In terms of primary functional patency, the 3 factors that were important, or what we found, was age, hypertension, and anastomosis. And the anastomosis that had the best primary functional patency was the brachybasilic, which, based on the size of the veins, that is not surprising. And it's also, the brachybasilic is actually a 2-stage procedure. So this is essentially a summary of what was stated, where patient age, anastomosis location, and the presence of the surgeon level affected the maturation. For study limitations, essentially it was a retrospective, non-random design which can affect the outcome. And even though the cohort is 279, it was still small, and the failure numbers were also small, so we couldn't draw any conclusions from that. And it was a single center study. Even though the study was conducted at UWI, however, I will put the caveat that there are lots of inter-parish referrals, so it could still be generalizable to the broader Jamaican population. And with the visiting surgeon having the highest maturation rate, that can also be caveated in terms of during the missions, they were given actually simpler cases because we wanted volume to get the most out of it, so that could also affect it. So my interpretation, our maturation is actually on target. We are 75% aligns with the threshold. Our primary patency could be better, however, it is still within the international benchmark. And the primary functional patency is definitely within the international benchmark. We did not have any AV graphs, which is not surprising in our setting, because the graphs would have to be purchased and they're quite expensive. And I don't think from my data, we thought that there was no indication for the graph, it's just that they were not done. However, satisfactory outcomes with our 2-stage actually showed that we can continue with our 2-stage rather than the AV graphs, but I suspect if I were to do some more work, I would find more graphs now. What does this mean for training? Residents performed 55%, but they had the majority of the failures. And one of these things that changed with this study was actually only residents who demonstrated competence can now go ahead and do the AV fistulas autonomously. Some other areas that could be studied, vesical fistula sequence, and we didn't look exactly on which residents failed and the amount of procedures or AV fistulas they did, so that could also, and more. So thank you.
Okay, don't go far. Okay, thank you, Dr. Spence. Are there any questions for Dr. Spence? Any questions or comments? Yes, Dr. Gabriel.
Hi, Dr. Spence. Thanks for that wonderful presentation. I just had one question. If many of these cases were done, or if some of these cases were done on a visiting mission, does it really accurately reflect what is being done at UHWI since a visiting surgeon is including in the numbers that you're doing?
No, if
some of the patients that were done by a visiting team, does it really accurately reflect what we do at this institution?
Well, okay, I see why you asked that question, meaning it wasn't our surgeons that did it. So during the visiting surgeon missions, though they are doing some of the volume, some of our surgeons are also there. And the aim was to look at fistulas done at university on our patients. But I can see where, yes, you could say that some of that, if we took out the visiting surgeon, what would be our maturation? That's an area that could have been done, but we didn't look at it, but that's a good point.
Okay, can you go back to your slide on the single stage? And I think there were Kaplan-Meier curves.
Yeah.
All right, what I'm not clear on is in this, are you counting only the basilic veins? Because you have single stage and you have 2-stage. So are you counting only basilic veins in this data representation? Because cephalic veins are always done single stage. Right. So I'm just trying to find out, is this just an analysis of your basilic vein outcomes?
No. So the single stage was brachiocephalic, radiocephalic, both proximal and distal, and the 2-stage was the the two-stage brachybacillic. So majority of the two-stage references the brachybacillic in terms of from the data that are collected.
So then I wonder, is it really fair to group all those kind of fistulas together?
The single stage?
Yes, because brachiocephalics, radiocephalics are always done single stage.
Yes.
Right? Mm-hmm. And brachiobacillics may be done single or two-stage.
Or two-stage, yes.
Right. So I'm not sure that it's fair to group those fistulas together.
You mean group all the single stages
all
together?
The single stages together.
So that's a reasonable point, because it is basically, from the data, you would know that the larger caliber veins have a higher patency as well as maturation rate. And majority of the distal radiocephalics in other settings actually show where their maturation and patency are low. What I found was interesting, which I didn't go into this part of the study, was actually, though the international data says that distal radiocephalic has a higher failure rate in diabetics, what I found in my study was that that really didn't impact. And when we did our distal radiocephalics, they were not, though not comparable to the larger vessel caliber like the brachiocephalics, they still had greater outcome. But I do take your point that lumping all them together makes it seem that they're one and the same as single stage, but so I do take your point.
Okay.
Okay, thank you. Coming next to face the batsman is Dr. Mitchell Henry from the section of radiology, and he will be looking at a retrospective analysis of the incidence of pneumothorax secondary to CT-guided lung biopsy at the University Hospital of the West Indies from July 2022 to June 2024. Dr. Henry.
Thank you. Good afternoon, everyone. All right. So I'm Mitchell Henry, and I'll be presenting a retrospective analysis of the incidence of pneumothorax secondary to CT-guided lung biopsy at the University Hospital of the West Indies. There are no disclosures. So lung cancer remains one of the leading causes of cancer-related mortality worldwide, and according to GlobalCan data, we saw an increase in 2020 of 11.4% to 12.4% in 2022. With rising mortality, according to this data, it went up from 18% to 19%. In Jamaica, lung cancer is the fourth most common malignancy that's documented, according to the Jamaica Cancer Society, and it accounts for approximately 7.5% of all new cancer cases. And this high prevalence demands that we have accurate, safe, and accessible diagnostic tools within our healthcare system to help with these patients. So CT-guided lung biopsy has become an indispensable tool in interventional radiology due to its minimally invasive nature, which allows us to obtain histopathological confirmation of suspicious lesions without the need for open surgery. This diagnostic accuracy frequently exceeds 90%, and while it dramatically decreases patient burden, healthcare costs, recovery time, compared to the traditional surgical approaches. And pneumothorax is widely considered the most useful metric in determining the safety profile of this procedure, with global studies reporting incidence rates between 10 and 30%, and in some cases even as high as 40%. And approximately 89% of all of these cases are typically found within the first hour. Up to about 11% of these patients may require chest tube placement according to the international literature. However, to current date, there's no local data available. So this raised the question, what's the actual safety profile of this procedure in Jamaica? So therefore, our primary objective was to determine what the incidence of this procedure was at the University Hospital from July 2022 to June 2024. And our secondary objectives were to identify and determine if there were, what were the patient and lesion-related risk factors associated with the process, determine the rate of intervention after pneumothorax, and identify if there was any mortality related to the procedure. So we conducted a retrospective observational cohort study over a 2-year period. We identified 72 cases, and after applying this inclusion and exclusion criteria, where we added all patients 18 or older who underwent lung biopsy at the institution and included lesions that were in the periphery of the mediastinum that were accessible by the transpulmonary approach, as well as we excluded all patients less than 18 years of age, patients with a pre-existing pneumothorax at the time of the procedure, patients with a prior biopsy of the same lesion, as well as patients with severe interstitial lung disease, which was defined by either radiological findings or pulmonary function test findings, and patients with insufficient records. Here I'd like to outline what our screening protocol is, both within the pre-procedural phase and post-procedural phase, but the main thing I wanted to highlight was when we're screening for pneumothorax, immediately after the procedure, we do an immediate post-procedural CT chest. At 1 hour and 6 hours, we also do screening chest x-rays, and patient vitals are typically monitored. So data for this study was predominantly collected from medical records, both physical and electronic, IR procedure notes, images from the PAC system of both pre and post procedure, and data from the laboratory information system. And the variables collected included demographics, presence of a significant smoking history, which was determined by if they had significant PAC smoking, and from the clinical history, as well as what were the lesion characteristics and what were the outcomes of these patients. So descriptive analysis was done with a 95% confidence interval, which predominantly yielded univariate analysis. So our cohort had a total of 68 patients. The majority of the patients were noted between 51 to 70 years, and this group represented about 58.9% of the total cohort. There was a slight female predominance at 52.9%, and only 22.1% of these patients had a documented smoking history. About 86% of patients had at least one comorbidity, with hypertension being the most prevalent at 55.9%, followed by an active cancer at 20.6%. And respiratory diseases followed third at 11.8%. So regarding the lesion characteristics, there was an upper lobe predominance, where just about 51.5% of all cases were noted within the upper lobes, with the right being more prevalent than the left at 29.4%. In terms of the size, the majority of the lesions were less than 4 centimeters, and the majority of the cases was noted between 2 to 4 centimeters, representing 33.8% of those cases. Most of the lesions were typically superficial, with a depth, which was the distance from the pleura to the lesion, of less than 4%, with 62.8% located at less than 2 centimeters from the pleural surface. Only 17.2% of the lesions were noted at deeper than that. So the primary outcome, so the overall incidence of pneumothorax, was noted to be 19.1%, with a confidence interval of 9.8 to 28.5%. When we looked at timing, we can see an incidence of 13.2% were identified on both the immediate post-procedural CT and the 1 hour chest x-ray, and this accounted for about 70% of all the pneumothorax that was documented. About 92% of these cases of pneumothorax were noted at the 6 hour mark on those chest x-rays, which was about 12 patients. We had one patient who had a normal chest x-ray at 6 hours, who later became symptomatic and was then found to have a delayed pneumothorax and subsequent imaging. So our risk factor analysis revealed some interesting findings. The lesion depth was the only significant risk factor that we found, which these lesions, the majority of them were between 4.6 centimeters with a p-value of 0.52, and 42.9% of these were significant. We didn't really find any other significant risk factors. Of all the patients who developed pneumothorax, 46% developed, were significant, whether they had a significant pneumothorax, a large pneumothorax, or they had symptoms. So these patients required chest tube, and this accounted for about 8.8% of the total cohort, which was about 6 patients. We found that the average length of stay for these patients was about 3 days, and only 11 patients had a prolonged admission, and these patients were mainly due to other comorbidities and not related to the intervention. There were no documented deaths. So the key findings for this is that we found that a rate of 19.1%, which is within the international standards, and here we can compare with different studies, for example, from Hearing et al., Polat and Rood. We see that this falls within the ranges of those studies. It has a good safety profile, meaning that we didn't really identify any procedure-related deaths. So the procedures in our setting is very safe. There was significant morbidity due to the fact that we had a high intervention rate, because this was higher than the international standards. We did find that there was some concordance with the literature, with the most significant risk factor, which was lesion depth. And there was some discordance in our study because we could not prove any relation between respiratory diseases and small lesion size. So this study had limitations. The main limitations were the retrospective design of the study. This meant that we could potentially have missing data and information bias, but we mitigated this by using multiple data sources and for cross-verification. The small sample size, while it is adequate for providing incidence, it's still underpowered in terms of doing risk analysis statistics. It is a single center study, and it may not be generalized to all Jamaican settings, but because this is a primary reference center for CT-guided lung biopsy, this data, the population is still skewed. And there were documentation gaps which limited how we could properly, adequately evaluate the mortality. So we can conclude from this study that we have an appropriate benchmark of 19.1% pneumothorax incidence, which is in keeping with the global literature. As we identified, 70% of these patients were identified on the immediate post CT and 1 hour chest X-ray. It's safe because we couldn't identify any mortality. Lesion depth was the most significant risk factor identified. We did have a high intervention rate. However, this just means that we have to plan better in order to try and mitigate circumstances for these patients. And these are some recommendations that we could potentially input into further studies in trying to determine how we can better assist these patients. These are my references. Thank you.
Thank you. Thank you, Dr. Henry. I'm sure that there are some questions and comments for you. We're going to start with Professor Gossel Williams. Could you give her the mic, please?
Thanks very much, Dr. Henry, for your presentation. I realize they're a very important area, but I'm having a little challenge with some of the epiterms that you used, you know. Incidence, are you sure you calculated incidence? And then, are you sure you calculated risk? I don't know if you want to actually approach those.
So because of this size, it was difficult to truly calculate risk because we couldn't really do significant analyses because of the small sample size. But it is something that can be further looked at once we have a more robust number in trying to truly identify what the risks are associated with this.
Right, so you throw out some terms where you really don't know for sure you didn't actually calculate risk.
No.
And the incidence,
so
no.
We tried to, but we couldn't.
Yes, so you have to present what you have. You know, a lot of us, when we do studies, the numbers don't work out, and so we have to pivot with the objectives that we can actually fit our data in. So I don't think risk was actually done, and I really don't think, I mean, EPI is not my first area, but I don't think that's incidence that you calculated.
Okay.
Essentially, what you looked at is what proportion of patients undergoing the CT-guided biopsy develop a pneumothorax. Is that correct?
Yes, sir.
And so that's not incidence, that's a proportion. And therefore, if you're talking about incidence, it's a rate, something that is happening over a specific period of time. So I think proportion or prevalence would have been a better term than incidence. Yeah. But thank you for your presentation. Colleagues, please put your hands together for Dr.
Okay, so from plastic surgery, we have Dr. Daniel Webster, who will be presenting on the natural history investigation into the genetic etiology of hidradenitis suppurativa. Please welcome Dr. Daniel Webster as he comes to the podium.
Hi, good afternoon. I'm Dr. Webster. I'm a PGY3 plastic surgery resident. I'm presenting on behalf of our department. This is an ongoing study that has recently met ethical approval, and it's on the natural history investigation into the genetic etiology of hidradenitis suppurativa. So hidradenitis suppurativa, also known as acne inversus, is a chronic, debilitating dermatological disease caused by complex but unclear factors, including multifactorial genetic origin. The prevalence is estimated at about 1% in the general population worldwide, and it leads to significant physical, social, and psychological dysfunction. So the pathogenesis has been described by Verneuil in 1854 as inflammation of the sweat glands, but further theories as it relates to follicular plugging were proposed in 1955 by authors such as Shelley, while authors such as Anderson and Doherty further ruled out this initial theory of inflammation of the sweat glands in 1958. So the current theory works towards principles of hyperkeratosis, parakeratosis, and anatomically abnormal follicles, leading to the subsequent pathology. So the pathophysiology of hidradenitis suppurativa involves first plugging of these ducts, subsequent stasis, superimposed infection, and dilatation of the ductal system. There's then a rupture into the surrounding tissues, with a subsequent autoimmune and infective response with the formation of abscesses, sinus tracts and fistulae, and finally, severe dermal scarring. So in terms of the classification of hidradenitis suppurativa, it can be classified in several ways. The most simple and commonly used way is the Hurley classification, which is a three-stage classification first proposed in 1989 by a dermatologist, H.J. Hurley, and it splits these patients into stage 1, who have single or multiple abscesses without tunneling or scarring, stage 2, who have recurrent abscesses with tunnel formation separated by normal skin, and stage 3 patients who have numerous abscesses across a large area with no normal skin separation. In terms of local data in our population, a 9-year collection of data by Mr. Arscott revealed that our population actually differs from the global population in terms of the prevalence of and gender breakdown of hidradenitis suppurativa. Worldwide, there's typically a male preponderance. However, in our population, we actually found that we have a female skew for this disease process. In terms of the anatomical zones, this is also different in our population as compared to the worldwide population. Typically, the groin, perineum, and buttocks are the most commonly affected areas worldwide, and this is especially common in men, while the axilla, which is more commonly affected in women, is found to be more commonly affected in our population. So as it relates to the genetics behind this disease process, hidradenitis suppurativa familial cases have been investigated in the past. We've identified mutations in NC-STN, PSE, NEN, and PSEN1, which collectively encode 3 of the 4 subunits in the gamma secretase complex, which is an intramembrane protease which is key for cleaving type 1 transmembrane proteins, including amyloid precursor protein and, importantly, Notch. And this Notch signaling is very important in terms of the etiology of hidradenitis suppurativa in these patients, as it plays a key role in skin homeostasis as well as the normal function of the inner and outer root sheath of the hair follicle. So despite these previous studies that have been done that have identified these associated genes in familial HS, this only accounts for about 5% of all of these cases. And new options for genomic interrogation technologies offer an opportunity to identify novel causal genes in other familial cases of HS. Just anecdotally, in our plastic surgery clinic, we've identified several families who have significant hidradenitis suppurativa burden, which is not in keeping with the sporadic rate. So in terms of our aims, it's to perform agnostic genomic analyses, not limited to previously identified GSC genes. with an emphasis on new inherited variants found in and among family members, affected family members. So this is going to be, well, it is already a collaboration between the University of the West Indies and the NIH laboratory in the US, via Dr. Hanchard as one of the lead researchers there. And the plan is to perform genomic interrogation techniques on whole blood samples from familial HS cases and their unaffected family members, as well as their affected family members. So we're to enroll individuals who have hidradenitis suppurativa and at least one family member up to the 3rd degree affected with HS, with these individuals serving as study cases, with unaffected family members serving as the controls. Clinical information in the form of their medical history, family history, will be acquired from each patient, with a blood sample being collected and sent to the TMRU at the University of the West Indies for DNA extraction. These collection tubings will be labeled with a unique barcode, which will be pre-generated by third-party software for the role of identification and anonymity. So this is just an algorithm of how these cases are going to be processed in the form of who will be recruiting in the US versus here. This is the consent form for this study. It just goes into detail on what will be done with the patient samples, their rights as it comes to having them removed or destroyed as desired, as well as what will be done with the data in terms of additional testing and what we will report to them in terms of any significant medical results. They will also be informed that all publicly presented data will have all identifiers removed. In terms of what will be done with the results, significantly and/or medically actionable results will be shared with the UA team, with counseling to discuss results with each patient, arranged with a genetic counselor who currently works at the NIH with Dr. Hanchard. In terms of what we hope to achieve, we hope to identify genetic variants which contribute to the hidradenitis suppurativa development in our sample population. However, it is possible that no such association will be found. While the proposed single gene analysis approach has been necessary to address a gap in genetic knowledge related to HS, this approach that has been used may miss previously unidentified non-GSE variants, and this may be better appreciated on genome-wide studies, such as is proposed in this dataset. In terms of limitations to the study, these include sampling bias, limited ability of the study results to be extrapolated to the larger HS population, and limited power. So in terms of the sampling bias, in our clinic, we typically see the most moderate to severe forms of hidradenitis suppurativa, and therefore it is possible that this will not adequately represent the entire population. To combat this, we are also going to be pulling from both the dermatology clinic at the UE, as well as the dermatology and plastic surgery clinics from the Southeast region. And we should also note that even if there's a relatively small sample size for high penetrance or rare disease processes, this may still be adequate. So in conclusion, ideally this research, supported by Dr. Hanchard's experience with the Undiagnosed Disease Network, will support improvement in diagnosis and subsequent clinical care for patients with this particular disfiguring disease. And this may take the form of genetic counseling, family planning, as well as therapeutic drug development. In particular, currently, agents such as adalimumab, which is a TNF-alpha blocker, have been developed as a result of these previous genomic studies which have identified these GSC dysfunctions and have been shown to be of significant benefit in patients with refractory and severe disease who have not responded to conventional therapy. And research of this type may also be a benefit in future development of direct gene targeting therapy. Thank you. These are my references.
Thank you, Dr. Webster. So this is a study to be done. It hasn't, okay. It's, okay. I am trying to wrap my brain around the title of your study. So explain to me the natural history investigation into the genetic etiology. Tell me, where is the natural history component?
Okay, so in terms of primarily the genetic etiology is probably the most important part of the title. It's primarily a genetic study. We are investigating, in terms of the questionnaires, the risk factors that these patients have globally outside of their genetics. However, the primary investigative goal is to identify associated genes. So potentially may modify that title.
Okay. Yes. Because when we think of natural history, we think of a disease progressing without any sort of intervention from its preclinical stage to end stage. Well, thank you. Are there any questions for Dr. Webster? Okay, so we wish you all the best in that study. All right, okay. Okay, so our colleague from our division of orthopedics is now here, I understand, and his presentation is loaded. He is going to be the last presenter of our residents, and I'm referring to Dr. Yannick George Johnson, who is going to be presenting a cross-sectional study comparing single versus combined routes of administration of tranexamic acid in primary total joint arthroplasty. Does it impact blood loss? Please welcome him to the podium.
Okay, good afternoon, everyone. I'm Dr. Johnson, and the title of my study is, as can be seen here, it's a cross-sectional study comparing single and combined routes of administration of TXA, which is tranexamic acid, in primary total joint arthroplasties. And basically what we want to know is, does it impact the blood loss? So this is my supervisor, as can be seen here, Dr. A. Amarali. And I have no disclosures. So just a quick overview before we get into the meat of the matter. As stated, the objective was to see if there was any comparable fall or difference in the fall in post-operative hemoglobin when TXA was administered as an intravenous route or in a combined route where it is given both IV and intra-articular at the time of surgery. The study population was about 154 arthroplasty patients spanning over a 12-year period or roughly a 12-year period from January 2013 to June 2025. And the outcomes that we wanted to measure was the mean fall in the hemoglobin, also looking at some secondary outcomes such as occurrence of symptomatic venous thromboembolic events and wound complications. So just a quick background. Tranexamic acid is a lysine analog widely used in orthopedic practice worldwide, predominantly for its known benefits in reducing perioperative blood loss, and these effects are mediated through its antifibrinolytic activities. So the study itself aimed to determine if there is an associated difference in this perioperative blood loss for primary total hip and knee arthroplastic patients at the University Hospital of the West Indies who received TXA via a single or combined route. And the rationale we thought was clear in that there's physiological benefits to reducing perioperative blood loss to the patient. And also there's a decrease requirement on a scarce commodity which affects us island-wide, which is blood products. The secondary effects of decreasing blood products or blood product consumption also imparts decreased complications to said patients. And also it allows us the possibility, that is, if we have reduced perioperative blood loss, to engage in an enhanced recovery protocol in the immediate post-operative period. So a brief look at the literature overview. So the most frequent indication for total joint arthroplasties of the hip and knee worldwide is for osteoarthritis, and that's something that we see locally as well. Vaughan et al. In 2015 actually looked at the characteristics, so to speak, of the arthroplastic cases that we saw locally, and he indicated that about 15% of individuals over the age of 65 suffered from osteoarthritis. In terms of a worldwide perspective, when you look at literature coming from the United States, the AOS in particular reports on an estimated or expected six-fold increase in the number of arthroplasty cases by the year 2030. In terms of something more local though, and close to heart, sickle cell patients, of which have an estimated 10% prevalence of osteonecrosis of the femoral head in adulthood, are one particular group of patients who have a high engagement, so to speak, with the orthopedic surgeon for a total hip arthroplasty. So patients with sickle cell disease account for a significant amount of morbidity locally, where 1 in 150 persons are stated to have the disease, and 1 in 10 are stated to have the trait, as per local data. And it's well known in terms of the morbidity associated with surgical intervention in this particular patient group, not least of which are potentially the occurrence of vaso-occlusive crisis, acute chest syndrome, sometimes warranting ICU admissions, particularly with significant or major blood loss, preoperatively. So tranexamic acid is one of the most significantly used hemostatic drugs, as it can reduce the volume of blood loss in surgical patients by approximately 34%. Despite advances in surgical and anesthetic techniques, however, there's still an associated large amount of preoperative blood loss cases as it pertains to total joint arthroplasty, where the estimated average is roughly 400 mils, but it can exceed 1,000 mils of blood loss intraoperatively. So when administered via single route, IV TXA was most effective at decreasing the overall fall in the hemoglobin and also the number of units of blood required for transfusion. In contrast, however, TXA injected through a drain left at surgery was most effective at decreasing the postoperative drainage. And it suggested that a combined IV and local dosing warranted further study. Currently available data is somewhat conflicting in terms of the efficacy of a combined route, which was one of the reasons that we wanted to impart on this study. And as stated, there is somewhat a paucity of research about this particular topic, especially as it pertains to the use of TXA in surgery. The only mention I saw locally was from Johnson et al., and not specific to surgery, but in terms of the utilization in a 2010 study. So the methodology, I stated it was a cross-sectional study where we utilized data that we gathered from orthopedic surgical audits from the prescribed period. In total, we identified over 400 potential cases, however, due to missing data, missing results. That number significantly dwindled down, which we'll get into. But in terms of the calculated sample size that we needed for this study, estimated it to be 122, divided equally between the two groups, in order to get a p-value of less than 0.05, and a confidence interval greater than 95%. So individuals were placed into one of two groups, as stated, which is the IV TXA, and the combined TXA, which is IV plus an intra-articular administration. The primary outcomes, as stated, was the magnitude of the fall in the postoperative hemoglobin over the first postoperative week, And this was really nadir in the sense that if there was multiple postoperative readings, we would select the lowest value. Secondary outcomes that were measured, as stated, was the occurrence of wound complications, and venous thromboembolic events in the first 30 days. These are some of the inclusion and exclusion criteria. And then, of course, in terms of how we analyze the results, t-tests were used to compare the means between the two groups. We further went on to stratify blood loss by categories in terms of procedure time, operative blood loss, and also the volume of blood loss in the surgical procedure in question. And thereafter, regression models were tested. Oh, there was a question? Oh, okay, sorry. All right, so to move quickly, this is just an overview of the data in terms of some of the demographics of the cases. I included the no TXA group for a reason that we can specify a little later on. But is there a mouse? Okay, I just wanted to highlight though that when you looked at the demographics of the three groups, they were roughly equivalent in terms of the mean age, sex demographics, the type of procedure performed, down to even the mean operative time. There wasn't any significant difference between the three groups. Likewise, this slide is showing how the different comorbidities was distributed throughout the study. Cardiovascular there should really just be hypertension. Oh. Can I continue? All right, so, sorry. There's a box plot indicating the mean fall in HB for the three groups. And when we compared the difference between the three groups, of note, the group in question is the last row, which is the IV versus the local TXA. We didn't find a significant difference between those two groups. Interestingly, when you compared IV TXA to no TXA and the combined TXA to no TXA, we found a significant difference, which is not surprising, but we just include it as proof of concept. We tried to stratify further based on looking at estimated blood loss, so dividing them into groups of 500, so those with less than 500, 500 to 1,000, etc., etc. Even when we did it this way, we didn't find a significant difference between the two groups. Of note, however, because of limited numbers, when we attempted to do it this way, we weren't able to ascertain certain analyses to make a determination, especially for the larger blood loss groups. So when we looked at excluding transfusion, because we presume that if there is administration of blood products, this would impact the post-operative blood loss. When we looked at just those that purely didn't have any transfusion, likewise, there was no difference. No difference when we looked at different procedures, so TKA specifically and THA. There wasn't a statistical significant difference between the two groups. Nor was there a difference when we compared them based on the operative time, stratified them from less than an hour to those that were greater than 3 hours. However, it also suffered from the same issue where for certain groups we didn't have a significant number of participants to make a determination. Secondary outcomes, there wasn't a significant number of cases of VTE or wound complications, but something that was thought interesting was comparing IV TXA to the combined TXA. There was a 4-fold increase in the number of wound complications. However, it didn't meet statistical significance based on a pairwise comparison. Okay, all right. So in conclusion, the results of the study demonstrate that the addition of intra-articular TXA to a standard IV TXA didn't confer any measurable advantage in reducing post-operative blood loss by way of the fall in the HB. These are some of my references. Thank you.
So we want to thank Dr. Yannick George Johnson for that presentation. I know we're out of time, but are there any comments or questions regarding his presentation? Yes, Dr. Baker.
Can someone bring the mic?
Thanks.
Dr. Johnson, can you remind us what your primary outcome was?
Right. So the primary outcome was the mean fall in the hemoglobin.
And
within the first
what would you have
week.
considered to be a significant fall in hemoglobin?
So the study itself was forward.
No, so when you were planning it out,
Right.
what would you consider to be a significant fall?
Right. So initially when we made the study, we actually powered it to detect a fall of 0.5 grams per deciliter. But as I can see here for in your eyebrows, that's not clinically significant. So there was some adjustment where we said we would try to detect a fall in HB about 1 gram per deciliter, which would be equivalent to an EBL of about 350 to 500 mils of blood loss.
Yeah, but hemoglobin from the lab is plus or minus 1. So the lab can't give you a precision that you're asking for. So if the lab says you take 2 samples and one is 10.1
Right.
and one is 10.9,
Okay.
you should consider those to be the same. So if you are doing your study and your tools can't measure that, it doesn't make sense.
Yeah, I see the point you're making.
So having said that, no TXA versus TXA, and you're getting a drop of 0.9.
Yeah, on average. Yeah.
So shouldn't your conclusion be that TXA isn't giving you any benefit?
You could make that assumption based on the parameter that you're trying to elucidate. Okay.
Any other comments or questions? All right, thank you. Thank you very much. It's always important to know the difference between clinical significance and other types of significance, statistical significance. We are at that pleasant point where the clinical research presentations have ended, and now our sponsor for the afternoon, Mrs. Ruth Hutton from Medical Protection Society, is going to address us. As she comes, I want to thank the IT personnel for the IT support that they have provided, and I again want to apologize to the persons online that we could not have engaged you more in terms of fielding your questions. We also want to thank Mrs. Ruth Hutton for providing the anticipated refreshments that we will be enjoying later. So please put your hands together for our main sponsor, Mrs. Ruth Hutton. Hello, Ruth. How are you? How are you doing?
Doing well, thanks. Good afternoon, ladies and gentlemen. How are you today? Wow, I hear everything. Heard it all. How do I transition the slides? You'll do them for me? Keypad, which is tucked under, no, not tucked. There you go. All right. So my name is Ruth Russell Hutton. A few of you may know me, some may not. I'm the Business Development Manager for MPS for the Caribbean and Bermuda. I try to make myself look busy sometimes, but sometimes I don't even have to try. So I just want to take 4 or 5 minutes of your time for those of you who have heard the words, the slang, the phrase, MPS, and you're not so sure what we're all about. Let me fill you in very quickly. We are the world's leading medical and dental protection organization for doctors and dentists, as well as healthcare practitioners across the Commonwealth. We are not an insurance company. We're a non-for-profit mutual society. So the moment you become a member, you literally become part owner. Membership provides you with access to expert advice and support, along with the right to request indemnity for complaints or claims arising from your professional practice. Every time I repeat our philosophy, I remember my grandmother who always said, ounce of prevention better than a pound of cure. Here to see it in black and white. We're here to support safe practice in medicine by helping you to avert the problems in the first place. Our global footprint is across the Commonwealth. And having been with MPS for almost 7 years, there's never a dull moment. You have the ups, you have the downs. And I pause just for a second to share one of the downs with you for those who are not aware. My colleague or consultant based in Jamaica, he was in Mandeville. He passed last year. Many of you would have received notifications with the name Andrew Bromfield and probably spoken to him many times on the phone and didn't know what he looked like. So we say rest in peace to Andrew. The rest of the team, we have Stephen Joseph, my rep based in Trinidad. And for those of you who would have listened in or joined in of any of our webinars or presentations, you may have seen or heard Dr. Brian Charles. He's based in Barbados. So how do we support you? Well, there are many ways. They're all there demonstrated on the slides, and I'm just going to pick out the hot topics. Disciplinary matters, criminal investigations, help with unwanted media attention, Instagram, TikTok, 7 o'clock news, Gleaner, Dr. So-and-so. And what do we mean by support? Support here means that you are assigned an attorney who will represent you, who will speak on your behalf in situations such as those. These are what we call non-claims. So doctors, we call them junior doctors below the consultancy level. These are the areas that you would benefit from the most. Red always means danger, right? So you're wondering, where's the biggie? Yes, it's right there, circled in red. You do have the right to request assistance for clinical negligence and claims support. Across the Caribbean, we offer indemnity limits based on the island, the economy, the location, and there are many parameters, but I wanted to pinpoint or to share with you one figure for Jamaica. Each claim for clinical negligence or case, you are covered, you are indemnified for a maximum of 270 million Jamaican dollars. And that's per claim, per year. Yes, you could be one of the unfortunate ones that's sued twice within a membership year. It does happen, but you would still be covered, right? Some take-home messages. Membership is free for medical students, interns, and senior house officers. And as the phrase goes, the higher the monkey climb, yes, the more the back is exposed. So thereafter, you are expected to start contributing. If you're not a member, I invite you to scan the QR code. It will take you to our join page. That's a quick and easy way to get in touch with us. And the application process is fairly simple, straightforward. Once you hit the send button, you get an automated response. However, I need you to listen to me very carefully now. It's important to maintain up-to-date and accurate records with us. Doctors, if your email addresses change, we won't know unless you tell us. If your telephone numbers change, we won't know unless you tell us. Yeah? So if anything within your scope of work has changed, we need to know your address, your email, your average number of hours worked per week, where you're working. Is it private alone? Is it public? Is it full-time public, part-time private? So we invite you, we implore you to check your emails regularly. Don't allow your memberships to be automatically cancelled for non-payment, because it does happen. And most of the times you're like, oh Lord, I never planned. No, it was a mistake. Let's just avoid it in the first place. And last but not least, Sunday we have our annual medical, legal, and ethics event, Spotlight on Risk. We started with 1 hour. It has grown over the years to 2.5 hours now. And we start at 11 in the morning. If you're interested, you can scan the QR code to register. That's 2 hours CE, already approved through the Medical Council of Jamaica. Yes, take out those phones and scan the QR code, please. And it's open to members as well as non-members. I invite you to share this link with your colleagues that were here, that are in your various groups, because it's about avoiding the risk in general. Each one, reach one. All right. And if all else fails, the QR codes didn't work, your phone wasn't working, take one picture of this screen. You can call, you can text, you can email. I'm literally a phone call away. And that's how you can get in contact with me. With that, I wrap up and ask if there are any questions. Silence is golden sometimes. I see a hand. Go back to the spotlight on risk. No, this one. Oh, my ugly photo. Oh, sorry, my beautiful face. There you go. All right. Any other questions? Yes, ma'am. You're not seeing the program? All right, once you register, an automated response is sent to you that would entail the program. But if you'd like, I have it on my phone. I can give it to you when we're done. Quick and fast. Yes. Any other questions? Well, thank you so very much for your time. I do appreciate it. It's nice and warm and cozy. Let's keep the love going and have a wonderful weekend if you do have such a thing called a weekend. And take care.
Thank you, Ruth. Thank you, thank you, thank you. So, colleagues, we are almost at that pleasant time where we will recess to enjoy the lovely fair that has been put on by MPS. But before that, we have the very important activity of our judging to come forward and let us know what her thoughts are on who had the best presentation this evening. So I invite Professor Gossel Williams to come forward and let us know who she thought gave the best presentation. Please put your hands together for...
Yeah. Okay, good afternoon, everyone. So let me first thank the organizers for inviting me to be part of the process in judging of these students this afternoon. So just by full disclosure, in case we all don't know, that I have nothing to do with medicine. That's not my training. I'm a pharmacologist, basic scientist. I do get involved in quite a bit in translational work. And I have quite a bit of research under my belt, and I was deputy dean for research at some point. So I am looking at everything from a perspective that is generic, but I do understand most of what was presented today. So overall, I will say congratulations. The presentations were all confidently done. Dr. Webster is escaping assessment today because his presentation was more proposal. So I look forward to seeing his later. But you all did a very good job orally in terms of the confidence that you showed. And even when some of the questions clearly indicated that there were some obvious flaws, you still made the attempt to answer it as if you were confident about your data. So I'm very happy about that, I guess. The presentations for me, what I found they were lacking is the actual lit review to justify why you want to do the study. You see, I saw numbers being mentioned, but you always have to remember that just like how your study is not generalizable because it's only being done in one setting, you can't present figures if you're presenting data from similar experiences. Justify your study, why you thought this intervention would work or not work. I didn't see much of that. There were some studies who didn't make any effort to show justification. But other than that, the numbers were good, and I really have to commend the surgeons for making the effort to do research. I mean, we didn't see any case studies this time, so I'm really happy to see the efforts being made. And there's some of them that really can produce good data. And I'm glad Dr. Baker is here because he can actually attest to the fact that there's something there, just needs a little stats work, right, Dr. Baker? And he's our strength in that. So overall, between the two judges, we had a challenge figuring out, we did go through everybody's and kind of figure out the strengths. And with all of what was said, we decided that we would work with a tie based on the discussion that we had on the scores we kind of worked on. Dr. Morrison, is that okay if we go with a tie? So the persons who are our award winners this afternoon, and I understand your prize will come at a later time. And perhaps moving forward, we kind of need to slant the prizes based on the disciplines. Maybe that will help next year. Dr. Spence Henry and Dr. Christopher Berry are our winners. Yeah. So it's really good work, and I'm looking forward to the publications. Whatever you're doing in terms of your DM and putting it down really does not benefit the university. So please ensure that you share outside of this realm and that you do actually publish the data. Thank you all for allowing me to participate, and I look forward to more participation here.
Good afternoon, everyone. So we come to the end of the program of another annual Department of Surgery Research Evening. As Professor Aiken said before, this activity is very important for us in a department as we aim to continue to publish and perhaps increase publication, but also to highlight talent of budding researchers, clinicians, surgeons, and researchers in the department. I'd like to just take an opportunity to give thanks to all of the students, to the residents who presented this afternoon. I know it's not so easy to get up in front of a crowd and speak, but you all did, and you did well, and so congratulations to you for that. For the supervisors who worked alongside these students in terms of developing the ideas, working on the statistics, thank you for doing so and pushing them. And as Professor Gus Williams said, we are hoping that there's always going to be transfer of this information presented here to published work. We thank Professor Gus Williams for taking the time to be here. Always very, very involved in our department, and we're really very grateful. And Professor Aiken for leading with charge in terms of increasing the output in our department. For MITS for providing support this afternoon, and from the Department of Surgery, Ms. Laurel Bennett for providing administrative support. For our sponsor, Medical Protection, thank you so much. Always been there and easy to call on, and certainly for you, all our attendees. Thank you, everyone. Have a good evening, and there are refreshments on the outside. Thank you.